Good morning, everyone. We're going to get started. My name is Olya Marcinich-Koloris. I'm a pediatric nephrologist here at LPCH, and I'm here in place of Dr. Leonard to welcome everybody to Grand Rounds today, and welcome on behalf of Department of Pediatrics and our Grand Rounds Committee. Initially, we want to recognize that Stanford University sits on the ancestral land on the Muwekma Ohlone tribe. As we do each Friday. I want to remind everyone to register your presence and attendance. You can use the text code to the left, and then you will be able to complete evaluations and potentially answer a few questions for MOC credit for your impressions today. Also, don't forget to give any suggestions and feedback for future topics. Moving forward, we will introduce our today's speaker in a moment, but I want to just draw your attention to the upcoming Grand Rounds. On February 17th, we will have Dr. Shelley Miyamoto talking about adult guidelines, directed medical therapy, and the failing pediatric heart. And then in our series, Pediatric Grand Rounds series in recognition of the Black History Month, we will have Dr. Jean Raphael talk about large-scale screening for social determinants in pediatric settings, Promise and Peril on February 24th. A quick announcement on our pediatric internship program at Stanford. We are now in a call for faculty mentors, and please feel free to volunteer. This program is called PIPS and is a 6-week summer research internship for underrepresented medicine Bay Area high school students. Our goal is to show students the exciting world of science, research, and medicine, and please volunteer to mentor these students and answer to this call at the code below or the email to our education department. And moving on to today's session, I will let our Dr. Splatcher and Lee introduce our speaker, but our session today is about the safety and quality journey in Boston Children's, which has centered on embracing the quadruple aim. They strive to become a highly reliable learning health system to improve safety, quality, and patient experience while engaging patients and families and recognizing the importance of the experience of the workforce. Our two professors who will be introducing our speaker today are Dr. Sara Packard, who is our Associate Chief Quality Officer, and Professor Grace Lee, who is our Chief Quality Officer here at Stanford. Welcome.
Thanks so much, everyone. I'm so excited to be here. It's actually my first Grand Round since the pandemic that I've been in person, so I'm really happy to be here. And thank you to those who've joined online. I'm so pleased to introduce Dr. Sara Toomey, who I've actually known for a little while now. She is the Senior Vice President, Chief Safety and Quality Officer, and Chief Experience Officer. She's holding 2 roles right now at Boston Children's Hospital, where she and I both trained. She is also director and principal investigator of the federally funded Center for Excellence for Pediatric Quality Measurement and associate professor at Harvard Medical School. She's previously a Rhodes Scholar, or I guess she still is one, but she did a Rhodes Scholarship, served in the National Health Service Corps, and worked in a federally qualified health center. And she is a graduate of the Harvard Pediatric Health Services Research Program, which is where she and I actually met originally. In her dual hospital leadership roles, she is currently leading and overseeing key safety and quality initiatives and patient experience, staff engagement, and organizational culture efforts at Boston Children's Hospital. And on top of these challenging and complex hospital leadership roles, she's actually somehow continuing an active portfolio of work as a pediatric health services researcher. So I find this all very impressive that she can do all of these things at once. She is very well known for her work on developing nationally recognized pediatric quality measures, such as the Child HCAP survey that's currently used by pediatric hospitals across the country to measure pediatric inpatient experience of care. And she's also continuing to conduct research on measuring and improving quality of care and how quality of care leads to health outcomes in children. I am so excited that she is here to give this annual patient safety lecture. It is a really great opportunity for us to really think about both as an academic medical center and as individuals who provide clinical care, how we can continue to improve that quality of care and that experience of care for the kids and the moms that we care for at our hospital. She's here today to share with us her thoughts, and I'm very excited for this, on embracing the quadruple aim and becoming a highly reliable pediatric learning health system to improve safety, quality, and experience for our patients, families, and our providers and staff. So please give a warm welcome to Dr. Sara Toomey.
Thank you so much, Grace. It's really wonderful to be here. It's been a short visit, but I can't tell you how much I've really enjoyed getting a chance to meet so many of you. The work you all are doing is just phenomenal. And so I hope there might be a couple kernels here to add, but that said, I really can't say how impressed I am at all that you're doing. The objectives, as Grace said, is really to give you a little sense of what we're doing at Children's. We're certainly on a journey, as I think all of us are in healthcare. I really am going to try to see if I can connect some of the dots between not only safety and quality, but also thinking about patient and family experience and also the experience of our workforce. So just to start to give you a sense of who Boston Children's is, we have about 485 licensed beds, around 1.2 million outpatient ambulatory visits annually, a little over 22,000 inpatient visits. In our workforce, we have around 16,000 employees, of whom around 4,000 are nursing staff and around 1,600 physicians. So it's a reasonably large pediatric hospital, and one for which there are definitely many moving parts. A few years ago, actually, before the start of the pandemic, we went through an exercise at Children's to really try to define for ourselves what our safety and quality sort of vision was for the hospital. And I really want to preface this by saying this work was done to really try to elevate what we're doing as an organization, and less about, although I'll be talking a lot about the program for patient safety and quality, less about what the program does. So at the highest level, what we are really trying to strive for is to deliver the safest, highest quality care, an optimal patient and family experience, and superior outcomes through our shared commitment of our workforce, patients and families, to a high reliability, continuous improvement, and the transformation of healthcare. And as I said, this is a journey, but it's always important, I think, to ground oneself in sort of what one's North Star truly is. Coming out of this exercise also, we came up with what we thought are the 6 sort of strategic goals. And really, I think of them more as pillars of the work that we do. Outcomes, safety, value, innovation, continuous improvement, and experience. And I really do think that all of these align quite nicely with all that I've been hearing about with the work that you all do. In terms of the program for patient safety, and as I said, this is the hospital-based program. For those of you who are familiar with Boston Children's, you probably know that one of its strengths, and potentially also a little bit of its challenges, is that we have lots of extraordinarily strong local teams. And so to say this, this is all in partnership with really amazing teams that are throughout the hospital in different departments and divisions and in different areas. But to give a sense, the program for patient safety and quality reports all the way up to the Board of Trustees. So I actually speak at every Board of Trustees meeting and give an overview of the safety and quality efforts that are ongoing. And under the program of patient safety and quality, we have, as it shows here, 4 main pillars. So patient safety, clinical regulatory compliance, quality management and performance improvement, and also our clinical pathways program. Underlying all of that are really threads around data systems and analytic capacity, and then our high reliability principles. Over on the right, and this is just a sampling, we certainly have many key partners that we work with. As I've come to appreciate, one of the goals in terms of promoting this work is really partnering broadly, breaking down silos, and really aligning, once again, people with that mission and vision to be able to drive this work. But some of our key partners are infection prevention and control, our Office of Experience, simulation, employee health and safety, patient relations, IT. We have a very robust surgical quality program and health affairs, just to name a few. from what I can gather, you also have multiple levels systems in regards to really trying to put safety first. At the top, there is, we have an electronic reporting of events and near misses, and we have a very structured approach for how we deal with them and track them and trend them over time. But to be able to really sort of drive this work, we're trying to be more proactive rather than reactive. And so in doing so, we are coming up with numbers of ways for which we can respond and can build resilience into our system. And I think a great example of that, in particular with these days with the behavioral health crisis, has been our behavioral response team that is able at any point in the day to come whenever there's a patient for whom they're coming escalated and can really help to de-escalate the patient in real time to avoid any safety events to either our patients and families or to our staff. We also have tried to embed more and more early warning systems. So whether this be our sepsis trigger tool or our DVT risk assessment. And I think these are the more we can figure out ways to hardwire these types of systems into our work processes and our EHRs, I think that we will be able to be even more successful in identifying potential events. I think knowing where I am at Stanford and Silicon Valley, I would say I think here too is a real opportunity for AI and natural language processing as we think about how we'll be able to develop more predictive models for pediatric care. And I'm really excited about what the future holds in that regard. And then lastly, we really do try to embed high reliability principles into our culture. This goes for safety, quality, experience, and for, once again, not only how we're treating our patients, but also how we treat each other. This is certainly, as I say, we're not always perfect, but it is something that I think we feel very strongly about and are committed to sort of improving upon. So I'm sure you all have a safety event review process, but for ours, just to say it very quickly, we review at both the local and at the institutional level every safety event that's put into our safety event review system. We also actually include all employee events in the system also, because really, once again, when you're thinking about safety, if we're not connecting the dots between our patients and families and workforce, we really aren't going to be able to develop those resilient, robust systems that we are all striving to do so. We do root cause analyses on many of the events in particular that are either externally reported or for whom they have serious sort of adverse events. But we also have been developing a much more robust apparent cause analysis program by which we're really trying to embed within local teams, trying to learn from what systems level issues could be identified through near misses and low or no harm events. This has been something that we've been really trying to also disseminate throughout the hospital, as I think these types of learnings really help to add to the foundation of psychological safety to really help embed sort of that notion of continuous learning. And that I think is really sort of where we're trying to move towards. Should also say that another way for which we review all of our events is through our M&Ms. We have multiple M&Ms that occur, so morbidity and mortality rounds that occur throughout the hospital. And we're revamping our approach to how we as an organization can learn from them. And once again, try to focus on those systems related issues that are identified and perhaps could also be spread throughout. It's also really important to understand what the culture of safety is at our organization. And so we've been moving towards an annual engagement survey of our workforce and have embedded within that a culture of safety questions. This is an example from a couple of years ago now. And what we do is that we create heat maps to look to see not only at which teams are really excelling, which teams need some additional effort to sort of to address some of their cultural issues, but also to look at a systems level to see where it is that we're really falling flat. So this is an example from a couple years ago where you can see our handoffs and transitions was an area where we really were not scoring as well as we had wanted. And from this came a renewed commitment to, for us, structured handoffs and using the iPass tool, and that's now been spread throughout and is used reasonably reliably within our teams. And now our next frontier is to make sure that we can be equally as reliable in using structured handoffs across the teams, which, as you know, can be a little bit more of a challenge. We also, emphasize in pediatrics how much we benefit from working together. And so these just give a smattering of different ways for which we're collaborating on our safety journey, whether it be through the CHA, PSO, whether it be through a numbers of collaboratives that our local teams are participating in that are supported by the hospital, and then solutions for patient safety. The more that we can work together, I think that that's going to improve the care that we're provided throughout. I wanted just to speak for a minute about how we embed patients and families in our safety journey. So we now have a family member who sits on our patient care assessment committee, which is the board level committee that's responsible for the quality and safety of care that we provide. We have families participating in all of our hacks and SBS sort of initiatives. We have multiple families that have been involved in our HRO, so our high reliability journey. I'm going to talk in a little more detail about that in a minute. We have families that are appointed to multiple governance committees through our patient care operations, and we're also engaging with them in the context of parent cause analyses and are thinking more about how we can, in a more intentional way, also involve them in our RCAs. Here's an example. So we started on our high reliability journey several years before COVID started, and in that setting, really wanted to make an effort of working across quality, safety, and experience. And we had family members that were involved from the very beginning. And as we started on this high reliability journey, we had to confront some of the real challenges that we had as an organization, and having them be partnered with us, having them hear what we were wrestling with, and having them help us shape what came out. It was really invaluable. As you can see here on the left, this is our every moment matters. So our core principles of high reliability: speaking up for safety, clearly communicating, and paying attention to detail. And what we then did a couple of years later is really try to evolve these and to say, sort of, how can we engage our patients and families in our safety journey? How can they be part of our safety team? So we created these cards, as you could see on the right, that we hand out to patients and families, for which we are translating these basic principles into what's most important for them. We also, in the context of rolling these out, created videos for staff training. The worst thing we could do is to encourage parents to speak up, and then when they do so, be dismissed by whomever it is that they're talking about the issue with. And so we created videos and did additional trainings to really, once again, try to promote our staff in understanding the importance and value of families being part of the safety team. And here's just an example of one of our family advisory council members and her story that she gave, which is around the importance of her voice being heard. She had a daughter for whom she was very complex, had multiple admissions over multiple years. And there were times when she would make observations, in this case, around our hand hygiene. And I think the beauty of this was just that our providers, rather than once again dismissing or making excuses, really worked with her to think about what we could do differently. And this actually ended up leading to actually tangible systems changes. I'm now going to switch gears a little and talk about our quality assurance and performance improvement dashboard. And this is our dashboard. It's we have one more month of data, so this is 1 month behind. But as you can see, this is what we are monitoring at the organizational level. The first measure is aggregated safety events, and this actually is a composite of a number of safety-related measures that mainly involve inpatient level of care. But what we've tried to evolve this dashboard to be is one that is aligned better with the strategic goals of the organization as a whole, and I'll speak to a couple of those in a second, and also try to go beyond inpatient care because this dashboard was so heavily focused on the inpatient areas, I think there are multiple teams that didn't feel connected as well to this work. A couple that I'll just bring to your attention are our new patient lead time. So one of our core sort of strategic goals for the hospital is to improve access to care. We feel as though that's central to our mission, and actually, from my perspective, is also a safety and quality related issue. And so the key performance indicator for the hospital, one of them for access, is this new patient lead time. And so that's something that we've raised up and put on this. In addition, as you can see, we have our DART rate, which is our measure of employee safety. And then the other one I'll just call out is our race and ethnicity collection. So in this measure, we recognized a couple of years ago that if we were serious about understanding where we had health disparities, we first need to understand who our patients and families were. At that point, we had a pretty, I'd say, inconsistent collection of race, ethnicity, and language. And so we initially focused on our ambulatory areas to really improve our systems and processes. So, and we recognize that, with this admittedly process measure, that if we can accomplish this and raise this to the highest level, that it would then allow us to take our next step. We actually were able to increase our race ethnicity collection last year to over our goal. So we're in our ambulatory area around 90%. And so what we've done this year to evolve the measure is that we're now doing it across the whole organization. So as an example, we recognize that we actually had pockets, in particular in our ICUs, where this information wasn't being routinely collected. And so some of the nursing team went in and did a deep dive, and they were able, in partnership with our Office of Health Equity and Inclusion, to create different systems. And we're really, I think, have done a really wonderful job increasing sort of those numbers. I wanted to just give a couple of examples about some of the work, recognizing, I'm going to give one example of work that we've done over years, and then another which is much more recent. So here is an example whereby we've taken and looked at sort of our adverse drug events over time, and really in a very concerted way, have had a multi-staged approach. But as it says here, this is a marathon, not a sprint. So this work has started back in 2006 and is still ongoing. But as you can see, we've been able to move the center line multiple times, and are still actively engaged in making sure that when we see blips, so for instance, when COVID started, that we're able to respond. Here's a more recent example of how we're using our dashboard and working together as a team. So this is our CLABSI rates per 1,000 central line days. As you can see, for multiple quarters, it was quite stable. Not to say that we weren't actively working on it, we were. But as you can see in FY, so 22 quarters 3 and 4, we saw a real uptick in our rates. And so that generated a whole bunch of work. We obviously partnered very closely with our infection prevention and control colleagues, did a root cause analysis that identified a number of contributing factors. Defective product was issued that we identified. We were able to recognized that we had an increase in new nursing and of agency staff, so our travel nurses. And we also had a decrease in our hand hygiene compliance in patient care rooms between tasks. So we then went about to implement a number of very targeted actions. So we were able to get rid of the defective infusion sets. So that part's obviously good, and did our required reporting. We revised our onboarding process, both for our staff agencies, but also in regards to refreshing for our new staff, what the foundational sort of CLABSI bundle prevention. And we established on-demand hand hygiene auditing programs. And I'm really pleased to say that as a result, this is the last quarter, we were able to bring down our rates. And so I think this just demonstrates that, with concerted attention across the organization, knowing that we have obviously many partners and many people involved that really can make a difference and can bring about change in a pretty rapid manner. As I had mentioned earlier, we do have an extremely robust department and division sort of quality and safety programs. In each of our clinical areas, we have triads. So physicians, a nurse or a technician, depending on the area, and also a quality improvement consultant. And these triads are responsible for a number of activities, from identifying and trying to demonstrate sort of the quality and safety of the care that their individual groups are providing. They are very engaged in on the front lines of some of the implementation of some of the organizational priorities we have. So as an example, IPASS, as I had mentioned earlier, our VTE prevention is another example, or sepsis. We use them to help us disseminate information regarding quality, safety, and also regulatory related issues. And they also help us to make sure that we're understanding what the work is being done for local teams, and making sure that we can align and connect the dots across the organization. To that extent, we've been evolving our systems of how we're getting that information and trying to move from at an institutional level from where it was, to be frank, a report out annually, to one for where we are trying to create a more dynamic learning platform that can actually be a tool not only for project management, but more importantly, also for sharing across the organization. So over the past year, we have built templates using smart sheets for all of the department and divisions. And what this has really allowed us to do is to aggregate and connect across. So we now can take a look, whether it be at an individual level or, as it shows here on the right, at the enterprise level, to see what people are working on and to understand sort of where some of our deficiencies might be. Our plan, this is by no means perfect. We're actually in the process of going around and meeting with all our teams, getting feedback around how this process went. But we already are hearing that people appreciate the transparency. So this dashboard is available for anyone in the organization who's involved in their quality and safety work to look at. People are using it to find where there are other programs or departments and divisions that are working on similar issues. And we're using it to sort of try to see if we can connect the dots across. So an example of some of that sharing would be our surgical colleagues were interested in working on antibiotic allergies. And they had no idea that our allergy immunology teams were very active in also working on dealing with this issue around allergies. And so by making that connection, they were able to develop sort of a better partnership and have actually been quite successful in decreasing sort of inappropriate antibiotic use in that context. Our clinical pathways program has also been something that we've been evolving over time. I'm sure you have a similar program, I'm sure whether it's clinical guidelines or pathways or however you refer to them. But for us, they're really educational tools that we do our best to embed into the clinical areas. We also do our best to share whenever possible and are in the process actually of rolling out an app for public use. But I would say we've been able to demonstrate in a number of areas how by using pathways we can decrease the variation in care. And what we're really moving forward with is trying to understand better how these pathways can then really improve the value of the care we provide. So I'm now going to switch gears and just bring in a little more explicitly sort of patient and family experience. Because, as you do look at the quadruple aim, it really is critical as you think about, once again, bringing together all of this work. And to start, just to be clear, patient experience is not the same as patient satisfaction. This isn't about whether the coffee was hot or that sort of thing. This really is, and I like this definition from Beryl, the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. And this is, if you're interested in experience, Beryl Institute is a great sort of resource, just more generally. But I think that this really demonstrates that this is more than what I think people often think of when they think of patient experience. And so why does it matter? And here again, there's actually very good literature to demonstrate that when people have a good experience, meaning they feel heard, they feel listened to, that people are explaining things well, that they're part of the decision making that's being made, they actually are more adherent with their care. It's also been shown to be associated with improved outcomes, whether it be for adults with glycemic control, asthma, admission rates. It's also fundamental in the context of trust. When we really are trying to be patient and family centered, if there isn't trust between families and their clinicians, there really can be a breakdown in the relationship and ultimately in the care. It's been shown to be also effective in the care that's being provided and can even decrease operating costs. There's some studies have shown a decrease in length of stay, certainly with adherence and other sort of models or other sort of outcomes. It can also decrease sort of costs. And so what does it mean to patients and families? This is a word cloud that our FAC made. And they spent a lot of time really thinking about what the optimal care experience was. And this is what they came to: excellence in care delivered with respect, compassion, communication, and collaboration with patients, families, and staff that results in overall health and well-being. I mean, to my mind, I think that's, what we're all striving for. And it, once again, it has become for us sort of a North Star in regards to our patient and family experience. And so then the question becomes, and a lot of people ask, why do we measure it? And so, as you all know, you can only improve what you measure to some extent. There is certainly also a shifts in consumerism and shifts in markets. And patients and families are feeling more empowered to make healthcare choices. And then I think the important piece too of why patient experience measurement is so important is really what it covers. So the best patient experience measures are those that cover what patients value and what patients can directly observe. So, we're not asking patients to say whether or not the antibiotic choice was correct, right? What we're asking patients and families to say is, did they feel heard? Were they respected? Did they understand what was being said? And the last piece is, it's really around what patients are generally the best source of the information. And so I've been in multiple conversations with clinicians for which they tell me they're a really great communicator. And then you go and you talk to the patients and families and you recognize that they actually maybe aren't quite as good as they once thought. And so, I think in that situation, we really are trying to focus it on those types of items. Grace had mentioned that at our center, we developed a child HCAP survey. And I just thought it was worthwhile to spend a couple minutes to just demonstrate sort of the work that goes into developing patient family surveys. We did an extensive amount of formative work, and this included also doing a number of focus groups across the country in English and in Spanish. We did another set of interviews that were for cognitive testing. And what cognitive testing is it's really the way for which we make sure that the people that are taking the survey understand the questions in a uniform way, in the way that we had intended. We pilot tested it. We did a national field test in nearly in 69 hospitals, and then ended after that with end user cognitive testing. And at that point, what we were doing is looking to see how patients and families, what they thought about how we were putting together the questions and items. And it was really extraordinarily informative. As many of you might be aware, the Child HCAP survey has 39 patient experience items, which then roll into 18 single item and composite measures. And this just gives you an example of the measures in the different groups. So as you can see, there are 5 sort of overarching areas: communication with parent, communication with child, attention to safety and comfort, hospital environment, and then overall rating. And the top box scores for these specific composite measures, you can see, ranged from a low of 56% to a high of 75. And this is just to say that there is certainly room for improvement across the board. And when you look across the hospitals that participated in the field test, each bar represents one of those participating hospitals. And you can see that there really is differences across variation in performance. So when you think about what makes for a good quality measure, having room for improvement and seeing variation are certainly critical. And so what do we do to improve on patient and family experience? And I'm just going to give you just a couple examples of some of the work we've been doing. So the first is in improving communication. So we've sort of taken the "what matters to you" mantra, which is something that many hospitals, I think, have tried to embrace, but really using it to create a tool co-designed with our families that would allow in the ambulatory setting for patients and families' voices to be better heard, and actually also to create a way for there to be a more efficient sort of encounters. This purpose of this in part was to address the concerns that many have around, I didn't know that they wanted to talk about this one and really important thing until, they were on the way out. And so how can we make sure that we're talking about what families want up front and create more empathetic connections? And so a number of clinics participated in this, and this just shows, while admittedly these are 4 different questions on the ambulatory survey. CP just stands for care provider. So concern for questions and worries, explanations of problems and conditions included in decisions and instructions for follow-up care. And so the gray, the bottom line, are the hospitals that participated in our pilot for What Matters to You, and the yellow are for those that did not. I'll acknowledge those clinics that participated at baseline were not as high performing. But I think what's most important here is just to say, by implementing this tool, we were able to see a greater increase over time in the responses for those clinics. I also wanted to spend a minute and talk about a study that we did. It was recently published, looking at racial ethnic differences and socioeconomic differences in patient experience. One of the great things about experience data is that there's a fair amount of it. And in that context, we were able to look at our data across different racial ethnic groups and to see that it did appear as though we had a disparity in experience, and in particular in our ambulatory clinic areas. So what we did is we basically set up a two-phase approach. First, to try to understand a little better, and then to sort of using design thinking principles, try to understand with that understanding, what should we really be targeting. So in the first phase, we did 80 semi-structured interviews with patients and families. They're around 45 minutes to an hour. And they're all of family members for whom their child had recently received care at one of three Boston Children's clinics. We then did a thematic analysis of that to compare themes and sentiments of the interviews. And looking at both differences in regards to race, ethnicity, and also in terms of socioeconomic status using a proxy of health insurance. And these are just at a very high level, some of the things we found. Insurance status was really a marker, even more so than race, ethnicity. Parents with public insurance had more interviews that we considered to be majority negative sentiments. These were long interviews, so we, as it says here, we defined a majority sentiment as greater than 70% of all coded comments as being either, or if there were greater than 10 positive or negative coded comments in any interview. And so what you can see is that in terms of public insurance, we had a higher proportion of 37% in comparison to 21% of interviews that would be considered a majority negative. And Asian parents with public insurance had the highest portion of majority negative sentiment interviews. We did see some racial ethnic differences, with Asian and Latino parents reporting more issues with our care systems. And what was also came out and was striking on a positive side is just the importance of staff interactions to the overall experience. So this was particularly so for our Latino parents, for where their connection to their providers was really central to their experience. So what we did is we took that and using some design thinking principles, really tried to think through what it would be, how we would understand this information and make it into some actionable targets. And from that, we identified three main objectives for these interventions. So the first was collecting information in a standardized, transparent, and consistent manner to make sure that families feel prepared and included and never targeted. We also facilitating and enhancing connections between providers and patients and families, and personalize the care experience. And lastly, setting clear expectations with patients and families before, during, and after the clinic visit, with ultimately the goal to establish an inclusive environment with a focus on patient, family-centered, personalized care. And just to give an example concretely of what's come out of that is we've been developing and are piloting now what we're calling a CARES clinician communication program, where we're doing an observation program combined with some educational offerings. And for us, what we did a bunch of work trying to understand for us what were we really trying to achieve, and came up with this as our acronym of CARES. So connecting and introducing, asking patients and families about their perspectives, really trying to embed respect and empathy, ensure understanding, and summarize and follow up. And so we're right now doing our observations and are hoping to be able to roll this out more broadly. In the last few minutes, I just wanted to make the point of also connecting the dots with the workforce. I think COVID, if nothing else, has just, I think, emphasized the importance for our workforce and how critical it is for us to be making sure that they have what they need to be able to provide the care that we want for our patients and families. As you all know, and Stanford is actually obviously has done so much wonderful work in regards to burnout, in particular for physicians. But if we don't have systems that are helpful for our workforce, that ultimately, we will fail. Then 2019, so right before the pandemic, the National Academy of Medicine came out with a burnout report. And even there, even before COVID, it was clear that we really needed to prioritize and make a point of emphasizing sort of what are those factors that are leading to burnout, and how do we help promote the well-being of our staff. From our perspective, we think about it, the different driver dimensions, and thinking about engagement as sort of that antithesis. And we've really been trying hard to do a whole bunch of work in this arena. So in regards to sort of our organizational culture more generally, we really are trying to promote our staff feeling safe and supported at all levels. And we have, through a multi-pronged process, came up with what we are calling the Boston Children's Way. That's really ties into these 4 basic values: respect, inclusivity, teamwork, and kindness. And this, you can find it on our website. This is really is guiding the work that we do, and we are trying to embed it within sort of our culture. Specifically, when we think about our physicians and faculty focus areas, and you think about the dimensions of wellness, we've identified five key areas that we've been working in: recognition, resilience in health, professional development, efficiency of practice, and community culture. And what we've done is that we've really tried to take a strategic approach. So, we're trying to create a culture of health, resilience, and well-being. It supports physicians and faculty in doing their work and living their lives. In terms of our mission, we are trying to optimize the highest levels of well-being throughout our community. And this just gives some of the things that we're doing in the different areas in regards to how we're approaching these. And we recognize that for this to be successful, it takes the buy-in of our executive leadership team, and really it's a collaborative effort across the organization. And here too, and some of these are much broader than just for physicians and faculty, but I will call out this one, which is we've now also this year had every department and large division to appoint a physician wellness officer. And this is really meant to bring together a community to heighten the importance of this work, and to provide a means for bidirectional communication, to learn a community for where physicians and other faculty members can learn, and also so that we can spread some best practices. We have a lot of materials that we have available for which we're trying to promote sort of different services that we're providing. And I think that while we still have a long way to go, that we really do have the buy-in from our senior leadership to really put this at the forefront of our work. So what I've hoped to do today is really talk through how these all connect. And I can't help but also talk about sort of what is being described the 5th aim, which is advancing health equity. And I would say here we are probably even, we're just starting our journey, over the last couple of years. But I think we can't end this conversation without acknowledging that, without an emphasis on health equity, we will never be able to really address underlying disparities. And I think that there are some things that we need to be doing in regards to measurement and incentives. We've certainly started to think about stratifying by patient and family characteristics, as I was describing earlier. And while there are challenges associated with it, I think the more that we can dive into that and really try to understand when a difference is a disparity and what our role is as an organization, I think that's going to be very important. Measurement of social determinants of health. I was able to hear about all the great work you all have been doing with food insecurity. I think that that's something that we're going to have to understand better, and understand what the role of healthcare is in addressing some of those. And then lastly, I do think that there's a role here for whether it's insurance contracts, or others, in our case in Massachusetts, our mass Medicaid, to really value health equity and incentivize improvement works. And I think that's starting, but this is hard and it takes resources. And if we need people to uh, not only value this, but also at times help us in doing this work. The other 2 points that just to say, because I think they're extremely important too, is that we really need to be more intentional in including patients and families with diverse backgrounds. This can be challenging, at least for us at Children's, because the patients and families that we really want to reach often aren't those that have the time to be able to participate in this standard approaches that we've currently taken. So we're trying hard to figure out what we can do. So as an example, on our Family Advisory Council, we now have simultaneous translation with one parent so that she can participate actively, so that her voice can be heard. But we recognize that even that is not adequate in terms of really getting the involvement and engagement that we need. So it's something I think we're all going to have to work on together. And then lastly, diversifying our workforce is also going to support these efforts. Children's, we have a strong commitment to working towards having our workforce mirror our patients and families. And in doing so, we really do feel as though that will contribute to the ultimate outcomes. So in sum, I think, we've really tried to embrace sort of frameworks where culture and learning systems are sort of central. It's been important for us to really make measurement and process improvement methods sort of a capacity at all levels. So not only at institutional at the highest levels, but down to the local teams. And we've found that, engaging patients and families in safety really does help to accelerate our work, in that we can make meaningful improvements, which I think is really important. And then lastly, it's really essential for us to be focusing on our workforce, and this does require dedicated effort. And then, to end, if we're really going to move forward, we need to focus on health equity and to identify and then ultimately find ways to decrease those disparities that we find. So thank you. I really appreciate the opportunity.
Thank you so much, Dr. Toomey. That was really wonderful. For those that are still online, please feel free to put your questions in. And also for folks in the room, you can raise your hand. Is there anyone in the room? Oh, Dr. Rosbach.
Thank you, Dr. Toomey. That was a really enlightening presentation, and I feel like we have a lot we could learn from what you guys are doing. I'm with the Pediatrics residency program, and I'm really interested in your behavioral response team, and I'd love to hear more about that, and also how you staff it and how you retain people who staff it. We're actively building our behavioral response team, and I think currently working through issues of recruitment and retention. And also just a special thanks to your site, because one of our fellows, Eliza Phillips, is going to be leading a multi-site study looking at the impact of escalated families on pediatric residents, and your site is participating. So thank you in advance.
No, our pleasure. I'm happy to connect you with our behavioral response team themselves, but at a very high level. It's nursing led with we're also trying to develop a sort of a psych tech position role, but it's mainly nursing and social work led. We do now have people actively in-house 24/7, and they do respond very quickly to events, and often are actually engaged in a more ongoing way with certain patients, in particular when they're on the floors, the medical floors. It's been challenging more generally in behavioral health to be able to hire and keep people in terms of staffing. But I do think that what we're trying to do is provide the needed supports to acknowledge that sometimes this work is really hard, and I think we've had pretty good traction keeping many of our team members. But I attribute that largely to who's leading them, and they're wonderful people. They really are.
Thank you. We'll take one from online, Dr. Toomey. One of the questions early on for race and ethnicity, do you know in some of those surveys what were the options given? For instance, Asian American Pacific Islanders are often lumped, and it might be better to collect subcategories such as Chinese, Filipino, etc.
Yeah, so for race ethnicity, for race, it's Asian Pacific Islanders. For ethnicity, we have many more options that people can choose from. So we usually use a combination in that regard. I think one of the challenges around that, and this is something that I think is going to evolve over time, is that depending on what the purpose is, I think it somewhat changes sort of how granular you want to be. But we do have that ability, because I agree 100%. People need to be able to self-identify.
Thank you. Let's see here, Dr. Lee, and also, is there another question? Oh, Karen.
Hi, Karen Wayman,
Dr. Wayne.
Family Center Care. I was interested in your interviews on your with the Latino population, and we're running a series of surveys and interviews with the lived experience of our Latino population, but we have response bias towards positivity. Everything is fine, so we really struggle to get those real responses about how what are the challenges in the hospital. So I was surprised at that finding. How did you get around that? Or
Yeah, so the positivity, at least at a survey level, has been shown at times for where Latinos are often do report sort of positive experiences in many ways. I think it was really just the fact that we had a pretty well developed interview guide and focused people on really walking through their actual, like what happened during an actual visit. And I think that helped us uncover where there were gaps. And correct. Yeah.
Thank you. I turn this on. Thank you so much. That was really thought-provoking and actually really helpful to me personally, especially as I'm beginning this journey with our team. One of the questions I had for you is, was the structure for division and department engagement and quality improvement already baked in to the way that Boston Children's Hospital works, or how did you encourage that? Because I think one of the areas of opportunity for us is to really build out division level improvement infrastructure. So how do you think about that? How is it supported? What do you think is the best way forward?
Yeah. So, I think Children's has always had a very strong local culture. So in that context, having local teams in and of themselves was something that I think came very naturally. And in terms of how that's supported, it's a combination. The hospital, we do try to provide some sort of monetary support, but a lot of it is sort of really done at the discretion of the department and division. Say one of the ways we're trying to evolve it, though, is that we now are creating what we're calling a pod structure for where every department and division knows who their quality improvement, performance and improvement person is, their safety person, their clinical regulatory person, and a data analytics person, and bring them together with the local teams to be able to sort of provide better support. But that I think that those connections for us has been what's been harder. It's less about stimulating great work at the local level. It's more about how do we actually create and align it across the organization.
Dr. Toomey, I'm from Dr. Singh. I'm curious, how do you build and mobilize a burning platform for patient experience throughout an organization, especially medical staff and faculty, just as it's done if you might see an uptick in a LabC or HAPI and so forth?
Yeah, no, it's a great question. I think for us, it's been a real journey. As I was sharing with some of you, I started working on experience back in 2015, and my role sort of grew over time. For us, it was first around sharing the data, and framing the conversation around the importance from a clinical lens. As I think you probably heard me say a number of times, from my perspective, experience, it really is associated with the best outcomes. And when you can start to connect the dots for people and talk about it, not about, once again, some of the amenities are from that lens, but talk about it from really how it can really support your patients and families best. I think that often will help ground the conversations. But it was a lot of local meetings and throughout over time, bringing people the data, helping them understand, recognizing when there were limitations, and then demonstrating that it could be improved upon, which I think is the other thing people don't recognize and I think discount it from that lens.
Thank you, Dr. Toomey. Last question, I believe, Dr. Kipps.
Hi, good morning, Dr. Kipps from Peds Cardiology. With respect to you, thank you for that wonderful talk. The patient experience, have you cracked the code on getting sort of real-time actionable feedback from families that you can use to iterate QI projects at like the local level, the unit level, or the division level? It's something we have struggled with.
Yeah. It's really hard, I think, is I think what we've tried to do over time is to shorten windows in terms of, of how quickly we get the data back, and try to circulate sort of the data in a more ready fashion. But I think it is really challenging, to be honest. I wish I could say I cracked that one, but I haven't.
We were looking for the holy grail there, but
I know.
swing and a miss there, Dr. Kipps. Thank you all so much for being here. Dr. Toomey, thank you so much for a fantastic grand rounds. Much appreciated.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.